Greetings, everyone. Welcome to the 129th session of the online Optom Learning Series. And for today's session with us, we have Dr. Vissett Sun from the Texas, USA. Dr. Sun is a class 1995 graduate of the University of Houston College of Optometry. He also completed his undergraduate studies at the University of Houston with membership in the Honors College. During optometry school, he was very proactive during his school days, and with that proactiveness, he was recognized as the outstanding first-year student and presented as his classmates as the president of the Optometric Student Association during his school years. Dr. Sun currently is in a group private practice, practicing along with 4 optometric business partners. He also is an adjunct clinical faculty member of the University Eye Institute and has been a preceptor for training the interns, the optometric doctors in family practice as well as in contact lens clinic. He has been on board of various organizations. He has served on the board of directors of the Harris County Optometric Society since 1995. He then went ahead to take up a position as the president in the year 1998 and 2015. In 1999, Dr. Sun attained his fellowship in the American Academy of Optometry. He also served on the AAO admittance committee for 10 years. And he has been also privileged to be awarded as a diplomate among the first class of board certified optometrists of the American Board of Optometry. And for all this work, Dr. Sun has been recognized by the University College of Optometry, Houston, as the Young Alumni of the year 2000. Not only that, but Texas Optometric Association has also awarded him the Young Optometrist of the Year in 2005. Very actively involved in social community eye care services associated with various Rotary clubs. He has been a member of the Rotary Club of Space Center since 1995 and has also represented as a president in 2004 at the World Convention in Osaka, Japan. He's also been a board member of the Foundation of Education and Research in Vision Science since 2001, and then went ahead and become a president of that prestigious organization in 2012. During the past decade, he has been associated with various organizations, as we mentioned, but most remarkably, he has hosted the FERV Fall Classic Golf Tournament, where he raised a lot of funds for the UHCO scholarship. I think the amount was about $100,000 US. And for that work, the UHCO has recognized him as a volunteer for the year 2013. Currently, he holds a position as the trustee of the Texas Optometric Association from 2018 to 2024. And with all that experience, knowledge, community services, and experience in the field of optometry and working with Dr. Earl Smith, Dr. Sun is going to talk to us about myopia prevention and his experience of how to go about helping patients with myopia. So welcome, Dr. Sun, onto our platform. Thank you so much for taking up this time. I do understand it's a very late evening at your end, but thank you so much, for doing this.
So I would say good evening from Houston, Texas, because it's past 10 o'clock at night here, but y'all are already in the morning. So thank you for spending your Sunday morning with me. I was born in Cambodia, so when we go visit over there, it's a 12-hour difference. But I think in Malaysia, y'all are 13 hours different. Yeah. So thank you for spending time with me. Gosh, I didn't know you could find out all that information about me. I don't even think I sent you all that information.
Some of them you did send, but some of them we do research as well.
Wow, you found a lot of information about me. Gosh, time goes by so fast because when I graduated in 95, that was 26 years ago. And those awards, they were 20 some odd years ago. So let's get started with the myopia prevention. Yes, I'm an alumni of the University of Houston College of Optometry. In the early part, the building was just this small building right here, this one-story building. And in 2012, we were able to build this 9-story building right here that has neurology studies in it. Now there is actually the College of Pharmacy built behind it. And then the University of Houston College of Medicine just opened across the bayou over here. You cannot see it. So a lot of times they say the father of optometry is Irv Borish. He has a really good book. That's what I'd recommend, that book by Irv Borish. Here's a picture of Dr. Earl Smith, Randy Reichley, and Irv Borish and myself when I was young. So I don't know if y'all are aware that this past week was the Brian Holden Vision Institute Myopia Awareness Week. Was this past week. You can always go and check on the bhvi.org website and find out a lot of information about eye care and myopia prevention. Of course, we're trying to prevent high myopia like this, where you have glasses that have such a high myopic prescription that it has to have a carrier. If you did not have this, this lens would be super thick. So they have the majority of this, must be over -10 prescription in the center. They also have the opposite with cataract surgery. You'll see cataract lenses that have a lenticular where there's a high plus in the center. But now that we put IOLs back in the eye with cataract surgery, you don't see these very much in the high plus powers. So the Brian Holden Vision Institute, they've been putting out a lot of facts this past week. One of the facts is myopia now is thought of as the leading cause of avoidable distance vision impairment. In addition to not being able to see, when you have a longer eyeball, you can have myopic degenerative conditions like maculopathy, peripheral conditions like breaks in the peripheral retina that can lead to retinal tears or detachments. Probably more prone to having vitreous separation earlier with high myopia. So I notice we do have a lot of students on the call. Sorry to go over this concept, but whenever the eye is nearsighted, the focal length of the light is in focus in front of the retina, out of focus that way. And then opposite from being farsighted, where the image is going to be behind the retina. But it's very, very interesting with myopic progression. It's this hyperopic focus that occurs in the peripheral retina that people think is causing myopic progression. So you see this theory of myopia is peripheral hyperopic retinal defocus was first suggested as a risk factor for myopia back in the 1970s. And there have been animal models that provide convincing evidence that the peripheral retinal defocus is what causes the elongation growth of the eyeball, even when you have a clear foveal image. So it's kind of odd. This peripheral retina defocus seems to create elongation of the eyeball. So I have a lot of parents or people say, well, why don't we just undercorrect the prescription? So if the person is a -3 myope, can we just prescribe -250 or -2 and prevent elongation of the eyeball? I think, well, oddly enough, undercorrection causes progression of myopia also. So I think the problem is when you have the glasses, in the periphery of the lens, it will cause a focus behind the retina, a hyperopic focus that creates the myopic progression. You can see this risk and benefits of myopia control. So they did a study to see if it was worth trying to prevent myopic progression. And of course, the findings were it was beneficial to do that. See, they have this statement right here that says, even with the incidence of myopic microbial keratitis from contact lenses, they say that slowing down the progression of myopia would be very beneficial. So there is this study, if you want to look that one up, risk and benefits of myopia control in the journal Ophthalmology, 2021, May the 4th, very recent. So, you know, when you talk about the animal models, I used to just wonder, well, how would a chicken model relate to humans? Turns out their life cycle is much faster than ours, and so they found out that if they occluded the eye, formed defocus, or even putting lenses on the chicken, they can create different lengths of the eyeball. So they would cover part of the chicken eye, and the light coming in to that part of the eye would not be in focus, or they use a hyperopic lens, and they created elongation of the eyeball. And you know, they just did half of the eye. You'd notice the outcome would be elongation in half of the eye, and the eye that got normal imaging had emmetropization. So you see the hyperopic defocus. So when you put a spectacle lens in the optical center, you get a good focus on the focal point you're prescribing for the person's prescription. But in the periphery, the spherical defocus will cause an image behind the retina, this hyperopic defocus. That's what they think is causing this stimulus for elongation of the eyeball, this peripheral hyperopic defocus. So if there was a way to utilize maybe an aspheric lens or an ad that can keep the focus on the peripheral retina like it is on the central retina, you can slow down the progression or elongation of the eyeball. You see, once again, this is an example of a contact lens. The contact tends to contour to the front of the eye, and the optical zone of the contact lens is probably more just in front of the pupil here. So we would probably have less peripheral defocus, but it turns out the higher the myopic corrections, you do get this spherical aberration of hyperopic defocus even with contact lenses. Here's an example of the you get the stimulus behind the eyeball, and you end up getting elongation, growth of the eye, actually axial length longer, which could be measured with like an A scan. So the dean of the optometry school, Dr. Earl Smith, a friend of mine, he was a professor of mine back in optometry school, and I did a lot of work with him with our Foundation for Education, Research, and Vision. And now he is back to doing his research. So Dr. Michael Twa is the dean of the U of H Optometry School. So Dr. Smith is trying to finish up his research. You see, he was the Charles Prentice Award. He put on a lecture in 2010 about a case of peripheral optical treatment strategies for myopia. So Faroukdin, he asked me to list some studies that y'all may want to look at. So you get a chance, you could research this Charles Prentice Award lecture in 2010 by Dr. Earl Smith. Actually, if you just research his name, you'll find a lot of literature about his work in myopic research. So he also had a paper about the development of and recovery from form deprivation myopia in infant rhesus monkeys reared in reduced ambient lighting. So that is probably more of a mammal similar to humans than the chickens. It's very interesting research he'd done. He told me that animals have much better image interpretation than humans, because if they don't see well, then nature would probably take care of, they would not survive and pass on their genes. So there really is a strong image interpretation in animals. But what they did is they actually were able to put minus lenses on the monkeys and created elongation of the eyeball. And during their development years, they could actually get the opposite effect if they put a myopic lens in and focused in front of the retina. They actually got the retina to grow less to try to match up with that image. So very, very interesting. There's also the International Myopia Institute, the IMI. They have yearly digests, so I would recommend, if you're looking for information about myopia control, look under International Myopia Institute, IMI. They have a lot of literature about myopic control. Ferguson, can you put the poll question about the who uses myopia control? We have people already instituting myopia control. Wow. Yeah, I'm very proud of y'all participating. We have almost 70% voting tally. That's very impressive. So here in the US, this is our Memorial Day weekend. Monday will be our official Memorial Day, so we are national holiday there. So I have a little longer weekend.
That's right.
Yes, so very, very impressive. 64% already instituting myopia control. Thank you very much for putting that poll question in. So there's thought about just being outdoors. The sunlight could be protective, preventing myopia. You have in the retina these G protein activated adenylene cyclase and phospholipid receptors that seem to help keep the emmetropization or slowing down the elongation of the eyeball. There is a magazine in the US, I don't know if y'all get its review of myopic management. They said that there's a mechanism that they think screen time can create myopia using computers and tablets. I've always had parents ask me if their children being on the phone or working on computers or tablets would create myopia. I think it causes eye strain. In the US, we like to use the term 20-20 rule. Every 20 minutes, take a break, look off at the distance 20 feet or 6 meters, optical infinity, to give your eyes a break for about 20 seconds. But I think what's happening with near work is the visual field that you see is a near target, which is diverging light. So that creates more stimulus for peripheral defocus than, I think, when you're doing outdoor activity, the light rays are coming in from different distances. And so we get the stimulus of not just a near target that could create hyperopic defocus on the peripheral retina. So I think that's really probably the big key. I don't know so much about the sunlight, but I do think being in a bigger area where you're not just focused on something in front of you, 40 centimeters, which can create the peripheral retinal defocus and axial elongation. So the Brian Holden Institute put out another myopia fact. It says 2 hours of sunlight a day is what they recommend. So I always tell the parents and tell the kids, spend time outside. Try to spend at least a couple hours outside. It can be helpful. So the different ways to try to control myopia beyond sunlight would be the pharmaceuticals, the atropine. You're very familiar with this 1% atropine. We used to keep it in our clinic in the exam rooms, but you'd be surprised what people would pick up and put in their eye, like, oh, my eye's dry, I'm gonna put this in my eye. Even contact lens cleaner, they mistakenly put in the eye, and you hear someone screaming because it's a soap, it's gonna burn. So this 1% atropine, well, it is very strong. It turned out a long time ago, ophthalmology would cycloplegic with 1% atropine, but that will keep the pupil dilated for several days to possibly a week. It's very, very strong. So you have the 0.5%, the 0.25%, the 0.1%, the 0.01%. So they've done research here with trying to prevent myopia with prescribing very low dose of atropine, and it seems to be effective. And does not dilate the pupil that much. It does not cause cycloplegia where it'd be difficult to read, that they have to have a ad. But getting a solution this dilute is difficult. In the US, we would have pharmacies that we can talk to, compounding pharmacies, and the pharmacist can make this low concentration for the patient. So you see, there are muscarinic receptors throughout the body. In the eye, we think of the receptors here in the sphincter of the iris, causing meiosis for the pupil to shrink, and also in the ciliary body. So the atropine is an anti-muscarinic medication that would cause the dilation, because it blocks the sphincter muscle, and also would cause cycloplegia because it would affect the ciliary muscle here that could not contract. So moving away from the pharmaceuticals, we were talking about contact lenses to control myopia or prevent myopia. So the Ortho-K, you would be fitting a lens that you wear overnight, a rigid lens, and it would be flatter in the center to flatten the cornea here. The patient would wear it overnight, and in the morning take it off, and this flattening effect would last 8 to 10 hours during the day. But what they think, in addition to flattening the cornea to the person's prescription, so they get a clear foveal image, this steeper peripheral cornea creates a plus lens effect that instead of having the light focus hyperopically behind the peripheral retina, they think this plus steeper peripheral cornea creates a plus effect. That is why the Ortho-K can be very helpful for reshaping the front of the eye. Now, not everybody is going to be comfortable with wearing a rigid lens or want to wear a rigid lens. So these presbyopic designs can be used for myopic prevention also. So Cooper has the Biofinity. That's the American trade name for it. I don't know what they use overseas. We actually have it under another name, Aqua Clear in the US, but they have a D lens for distance, the letter D, where they would have the distance optics in the center here. With the ad or a plus periphery. They also have an N lens where the central power is the ad or the plus power, and the surrounding power is the D. But these models, they're talking about clear foveal image, and trying to reduce the hyperopic focus behind the retina by using a plus lens here, a plus surround. So you see AccuView Oasis, they had a multifocal lens design. I was part of the design team. AccuView, actually it was AccuView Multifocal. This is a newer one, the AccuView Oasis, but the one we designed, it did not really give a good retinal image, and we actually had to coin the term. It was about 20/40 at the distance vision. That would be probably 6/12. Snellen acuity, and so we would call it 20 happy vision because they could not see 20/20 or 6/6. So you also have this Cooper makes this MiSight lens that is FDA approved now in the United States for myopic control, myopic prevention. So the United States FDA has approved this Cooper Vision MiSight lens that has the near distance with a concentric surround plus power, and then a distance and another surrounding plus power. This Visioneering natural view lens, I don't know if you are able to order this overseas. It's a smaller company in the United States that has this. It's usually used as a multifocal for presbyopic design, but this near center with a about a +3 aspheric add into the periphery gives the same effect of myopic control. So you see the Cooper Vision Lens MiSight. It's a one-day lens, comes in a 90 pack, commercially available in the United States. Should be overseas, FDA approved for myopia management. It's the first soft contact lens proven to slow the progression of myopia in children age 8 to 12. When they wear the MiSight contact lens, they have a clear vision, freedom away from glasses. And they said that corrects nearsightedness and slows the progression of myopia in children 8 to 12 years old by 59%. So outside of the contact lenses, there are glasses. What can we do in glasses to prevent myopia? Well, it would include some type of add, but typically glasses would have an add from eye level down. The reading power would be in the lower part of the glasses. So this executive bifocal, they actually think this is probably the best design for an add in glasses to slow down the myopia, because it's so large, it would provide a much larger retinal image, theoretically about 50% of the retinal image by using such a large add. Now, how much add would you use? Dr. Earl Smith told me that the more the better. He says +3. I would say 250. A lot of times, if you're trying to calculate the ACA ratio, you would find that a +1.5 is commonly prescribed for patients that have trouble with accommodation, poor accommodation, insufficient. +1.5 is pretty common add for that, even when you calculate it out. But I think if you're trying to perform or try to create myopia prevention control, you should consider an add of at least a +250, maybe even a +3. It would make the reading distance a little closer, but that is what they think we need, is to keep the peripheral retinal defocus from behind the retina to in front of the retina. So when you think about glasses, we've used progressive for trying to slow down myopic progression. Sometimes it seems to work, but in theory, this segmented executive bifocal would be the best. I think if you're going to use a flat top, usually flat top 28, maybe you should try to use flat top 35. if you cannot get an executive size one that goes all the way across. So this is gained U.S. approval here. FDA is to use these lenslets, this center distance focus with these little small 1 millimeter lenslets. So you see this diagram here. These little sections will be 1.03 millimeters in size, and there's about 400 of these in a 33 millimeter diameter around this central distance zone. This is what they're proposing to use in glasses. Now, you would think it would have it would not be clear, but I hear that the people look pretty normal behind these, and the people who wear them can see through them. So you see these lenslets. What will happen is it will cause a lot of different focal points inside the eye, mainly in the periphery. We want to keep the defocus from being behind the retina, in front of the retina. So that's what those lenslets are designed to do. Stellit, Stellus, this is the Essilor's name for United States lens design. I don't know if they're using this name worldwide, but in the United States, it is called the Stellit. It is FDA approved, United States FDA approved to prevent myopia, slow down the progression of myopia in children. So they said that after the first year, the trial results demonstrated the eye growth. 9 out of 10 of them were similar or slower than non-myopic children. So the United States FDA fast-tracked this into approval for myopia prevention in the United States. So once again, we have the Stellit design using this, what they call HALT, HALT. It stands for highly aspheric lenslet targets. So those little small lenslets, they actually have a name for it, the HALT, highly aspheric lenslet target. So it says consists of constellation of aspheric lenslets spread on 11 rings to create a signal that slows down the elongation of the eye. So they say, you know, Essilor noted that the power on these rings have been determined to guarantee that a volume of the signal is always in front of the retina, and following the shape to slow down the progression of myopia. So actually, I asked Earl Smith about this. I said, do we have to have a central distance with near surrounding contact lenses? He said that most of the popular soft contact lenses for presbyopia have a distance optical zone with a near aspheric add that's plus. He says that could work, but turns out now that we have FDA approved lenses like the MySight and the HALT technology, you probably would want to follow that type of technique. So the Brian Holden Vision Institute, Brian, Dr. Holden was an amazing optometrist. Unfortunately, he had a heart attack and passed away, and he left a great legacy of these vision institutes to help with research for eye care. So I know this slide is very small. I broke it up to the first part. He says you want to diagnose the myopia. So number one, we're going to examine the patient and determine the refractive state of the patient. Once you determine that they're myopic, then the next step on the other side of the arrow here would be you monitor the progression. So there are biometers that measure axial length. I didn't put a poll question of how many of y'all use a scan to measure the lengthening of the eyeball, but they say that if you're going to do myopia control, this would be an important part of the measurements. Not only measuring the refractive status of the eye, but the axial length to see if it's the actual lengthening of the eye is slowing down. And then the last part of this, the myopia management part, they say that every young myope should be able to be helped with myopia management. And once again, they recognize Dr. Earl Smith's research with myopia. Well, I want to thank you for listening to the program. Can we put the other poll question about, I wanted to know, what is your choice of myopia control currently? Yeah, between using spectacles, contact lenses, and or pharmacologically. I do think the spectacles, younger, it would be much easier to prescribe it in the spectacles. And so if you can use the Essilor's Stellate lens, or I think you can prescribe ads, use a flat top 35 or executive lens, and you can slow down the progression of myopia with that.
All right. So I think we see about 63% of people who are currently, using spectacles as the most common myopia management technique. And we have contact lenses and pharmaceuticals being slightly lower. I do understand because of the availability, maybe. I know that in this part of the world, probably the Asian continent, pharmaceutical management is a bit challenging because of the prescribing rights and therapeutic rights of drugs, where we as optometrists do not really prescribe independently atropine. But we do know that it's kind of a wonderful myopia management, and there has been a lot of evidence, as you discussed, about the concentrations. They have a lot of studies being done about different concentrations. So that's a bit of challenge in this part of the world. But I guess in the nearby future, it would be better. But ophthalmologists, some ophthalmologists do prescribe atropine as myopia management. I know some of them personally.
Yeah, I think because they're myopic, they have to have some type of optical correction. So they're going to either be wearing glasses or contact lenses. So that's going to be a default. They're all the myopes, they have to have some kind of optical correction. They're already going to be wearing glasses or contact lenses. And then, yes, if you want to use a pharmacological agent like atropine in low concentration, you can do that. I would not recommend using 1%. That would be horrible.
All right, and just out of this poll question, that's my just thought which I want to ask you. What is your best management technique if you get a patient who has myopia and you know that the myopia is progressing? Which one do you choose? Would you go ahead with spectacles, contact lenses, or pharmacology? What's your personal favorite?
Well, we have a very big contact lens practice. We tend to manage more with the contact lenses, but every myope starts off with glasses first. And then I think as they get into 12, 13 years old, they will move into wearing contact lenses. We don't have very many 8-year-olds wearing contact lenses, so I think they could, but a lot of times the child at that age is not psychologically ready to put the contact on. So I think you have to start off probably with spectacles. And then when they get to the age they feel comfortable wearing contact lenses, then you'll use the contact lens.
Okay. And by spectacles, do you mean the stellate design or myopia management?
Well, they, even though they have made that name, I have not prescribed. We have a big Esler account, but I have not had the Esler rep come and present it to us yet.
Okay.
But I've seen literature now talking about stellate. In the United States, our American Optometric Society meeting is Optometric Association will meet in June. That's our big national meeting. They'll probably roll it out then. The Academy meets in October in Boston, and I'm sure by then they will be presenting that lens.
All right. Okay. And I'm not too sure whether it's the same here, because I think in Asian market we have Hoya lens, which is the Mio.
Hoya. Okay.
Yeah. Which is similar to the Lenslet design. I'm not too sure whether it's the same design, but different companies are taking over. I'm not sure, but it's a similar design, the Lenslet design which you were mentioning, but it's been marketed in Asia, I guess. At least I know in Malaysia is the DIMS technology. It's known as the defragmented the segments, the DIMS technology.
Yes.
And I'm not sure whether it's the same as the Lenslet. I think we'll have to think.
It should be very similar.
Yeah, probably it's a kind of similar. And that design came out of the Hong Kong Poly U technique. So it was from there. So that's been very big here, at least in Malaysia. They have started for the past 2-3 years. And we have a couple of good results coming out as well. So first of all, I think thank you, Dr. Sun, for taking up this myopia, because I know it's a multifactorial thing, and we had a couple of sessions as well, and we were talking about this. But the more we know, the more we learn, right? So we want to know different experiences, and thank you for sharing your thoughts on that. And what
thank you very much for letting me speak.
The pleasure is all ours. So I'm just going to take some questions which popped up on the chat. And the first question here asks about undercorrection. So you did mention about undercorrection being a total no, and it actually is not a good option, because undercorrection also is a factor which
causes retinal defocus.
Causes axial elongation. Are you aware about any particular studies or the rate of progression of undercorrection? Any thoughts on that? Does it progress faster or slower or something like that?
I don't know the particular studies, but I do know that I've read that undercorrection can cause more myopic progression.
That's right. Yeah.
It sounds like it would be reasonable, the right thing to do, but it's not. Someone who's undercorrected, they tend to become more myopic even faster. So, whenever we're prescribing for the children, subjectively, they may not pick exactly the right prescription. So do you overprescribe? I don't think you should be too worried about missing by a quarter or a half, but I would not intentionally try to over minus someone. That is not going to be a good idea. And then undercorrecting, that's not a good technique. Undercorrecting the periphery with the ad, but the foveal focus should be corrected best. But I think if you Google or search, you'll find studies about it.
That's right. Yeah, I just kind of remember one study which I read it. If I may chip in here, there's one study, I think we can share the link on the chat. It's a study where undercorrection is not a way. So we're just posting the link, and if you want to read that study, if that's helpful. But I think, Dr. Sun, you're completely right that it's not this study only, but there are many studies out of various ethnicities, as you mentioned, that undercorrection is something which we shouldn't be practicing at this point of time already. It's proven. It's a fact that you can't undercorrect your patients. Let's look at another question on how to modify refraction strategies to prescribe multifocal contact lenses or executive bifocals. So do you do some modifications in your refraction, or you would probably just stay to what you got, or any tips?
Oh, well, on the spectacle, the ad, I think you refract the distance power and then prescribe plus 250, maybe even plus 3 if you want.
Okay.
Yeah, at least a plus 2.5 or plus 3. Now on the multifocal soft contact lenses, if you're using the MySight lens, the ad is already correct. So you're just prescribing their distance correction. The ad's already built in. They don't let you select the ad. It's part of their design, their patented design.
That's right. Okay.
Now,
So
if you're trying to do it yourself, once again, I think the peripheral defocus, you probably would want it as much as possible into the vitreous or in front of the retina. So it would probably be a 250 ad. So once again, one of my business partners, his teenage boys, he's been prescribing a high ad or plus 250 ad to his teenage children.
okay, right. So basically, you do not suggest to modify the distance prescription. Keep the distance prescription what you got, while you're performing refraction, and just add a top on of plus 250 or a plus 3 ad, which will create the peripheral defocus, right?
Yes, yes. Yeah.
Okay, great. So that's wonderful. So we do not modify that. And do you think that increasing text size or the font size while using phone or digital devices would help to prevent myopia progression? Any thoughts on this?
I don't really know if there was a study for that. It's still a near target. So I think people may think that a small font can make you more nearsighted, but I think what happens is when it's smaller, you want to lean in closer to see it. So if it creates more of a closer near target, that's going to create more diverging light, which can cause more peripheral retinal hyperopic defocus. I think font size is probably just to the comfort of the patient, and they really should do a 20/20 rule. Well, in the U.S. we talk about feet. I don't know if y'all say a 6/6 rule, where every 20 minutes, well, it's good with 20/20 rule. Every 20 minutes, look off the distance 20 feet or further to get a distance focus.
Yeah.
So you could say every 20 minutes, look off 6 meters to do a distance focus with the eyes.
That's right. I think we do use the same rule, 20/20/20 visual hygiene rule. I think it's universal in that sense. Yeah.
Yeah. So y'all talk with feet also then.
Yes. We do.
Okay. Yeah. So I think it's the font sizes to comfort, but when they're smaller, people tend to hold the phone closer to see it. So a larger font may allow you to hold it further, which that is the helpfulness is further target. Being closer creates more divergent light, which can create more peripheral defocus, hyperopic defocus.
All right. Okay. Thanks for sharing your thoughts. And do you think that MEM retinoscopy, the monocular estimation method, whereby we can measure the lag of accommodation, would that be something which will be useful in deciding or prescribing patients? Any thoughts on this?
Well, I think in the optometry school in the pediatrics department, they talk a lot about MEM retinoscopy. In private practice, I don't utilize that. I will use retinoscopy if we can't get our autorefractor to give a reading. I think if you can't trust the refraction, you probably would cycloplege the patient and refract that way. So dynamic retinoscopy If you like to use it and you're good at it, then I think you understand how to use it. But in private practice, I don't use MEM retinoscopy.
Oh, okay. And just a connecting question, you did mention about cyclopleging patients. So would you cycloplege all myopic patients, or you would choose in terms of if they are progressing, or only if you want to prescribe anti-myopia strategies, you're gonna cycloplege?
Well, it's very interesting. Usually the patients I end up cyclopleging are the hyperopic patients. Okay. More than the myopic ones, because you can have a +3, +4, +5, +6 hyperope that when they come in, you're only measuring +2 or +3. I think when they get out to like +4, it's probably worth at least one time find out how hyperopic that patient really is, because usually they do not become more hyperopic. You just never found the full amount of the hyperopia. So I tend to cycloplege more of the hyperopic patients than the myopic patients. I guess I feel more comfortable with the myopic patient, because when we're refracting the patient in the phoropter, usually when I'm asking which is more clear, lens 1, lens 2, I like the strategy of at least going a quarter more plus to at least a half more plus, because when you're plus a half, under minus for the myope, they can tell it's not as clear. It's very obvious. Most people that can see 20/20, their just noticeable difference J&D is about a quarter diopter, 0.25. So there are patients, if they're a quarter under, they can still see 20/20. A half under, maybe, but a half under corrected is very obvious to most people. So that's probably the main reason why I don't really cycloplege them, unless I just have someone that, maybe the person reads 20/80 on the eye chart, and they're selecting -3, and I think this is way too much. I don't believe they're that nearsighted.
Suspicious case, probably. You think he's accommodating too much or something like that.
Yeah, or malingering. Sometimes hey, why is it they cannot see? So just go ahead and cycloplege them, and then you can use retinoscopy.
That's right. Yeah, that's great. All right. And anything you would like to add on in terms of pediatric patients and features, clinical features of myopia, and do you want to elaborate on any correct procedures which we should be performing? So if you see a patient who is myopic, who is a kid, what features probably you look at to know that this is a myopic patient, apart from refraction, basically, which tells you that he might be myopic? That's probably how I would rephrase it. And
well, yeah, I think, visual acuity, entering visual acuity. So if they're uncorrected, if they don't see well, they could have astigmatism. They could be very farsighted, but usually myopic patients, they cannot see far. They can see near, and then refracting them helps you determine that's probably the number one clinical feature. I think if you had a biometer that would measure axial length, you can try that. But I think that's kind of tricky, because corneal curvature and axial length adds to the equation of their refractive status. So you can't always just measure eyeball length and say, oh, okay, this is myopic, because usually, the eye is 22.5 millimeters in length, not exactly 1 inch. That'd be 25 centimeters. But I usually tell patients that for every 1 millimeter, it's about 3 diopters of prescription. So it's a very minor, small amount. So if you're trying to scan axial length measure patients, I think it's much faster just to refract them.
Mhm. Okay, great. So that's again very useful. And a couple of more questions. This is related to the current scenario where we are all on digital devices. Kids are on online schooling. So and at the same time we say that outdoor activities and you did also emphasize about outdoor activities, which has to prevent myopia. So do you think that if kids are taking their schools or doing their online classes outdoors, probably at nearby the window or the balcony where there is bright
Yeah.
natural sunlight, would benefit? Do you think that would help?
That's a very tough study to do because I don't know if you could really isolate that it was the sunlight that caused that or the brightness of light. There's been talk about having bright lights in the infant's room to stimulate vision and maybe prevent myopia. But I think the sunlight and being outdoors, doing activity that's not near work is probably the best thing, because whenever you have that near target, that's your whole vision. If you're just seeing a near target, it's diffracting light that can create the peripheral defocus, retinal defocus, hyperopic defocus. So I think looking off at distance targets is the key.
Okay.
And the sunlight.
All right. Yeah. So so probably it's difficult to do a research out of it, but I think trying would be an harm. I guess I don't know whether you want to try and see whether clinically is it relevant or not.
Well, it's probably not a bad thing to tell children to go outside and play, but it depends on maybe the community they live in. Maybe there is not a place for them to go play.
Yeah.
That is unfortunate. I think you can't tell children not to read. I tell the parents, hey, if your child likes to read, it's okay. We can prescribe for their vision. But when you're 20 years old, if you didn't feed your mind, you can't just prescribe glasses for not reading for 20 years.
That's right. Yeah. True. So the other development has to happen, right? They need to develop their selves. So that will, of course, they need to do their near activities, and reading is one of it, which we can't find ourselves away from it, right? So it's important. But then, as you said, it's important for us to inform the parents, and very rightly pointed out, because when you say that near work causes more of myopia progression, and then the parents will come up and say, oh, but they have to study, right? So that's something which we need to tackle, and we need to advise accordingly. So,
well, I think if you prescribe the glasses that have an ad like that, they can read.
They can read, yeah,
as much as they want.
That's right. Yeah. So anti-myopia strategies as the bifocal, the executive style, or the spectacle lenses, which are there available for management of myopia, can probably be prescribed, and then let them enjoy their reading, right?
Yeah, and the vision. I saw that vision therapy question pop up. We have a vision therapy clinic in both of our practices. I think the ones that have poor accommodative control, accommodative therapy could be helpful. Maybe some vergence also. But I think the big key with myopic development would be less near work, unless you have an ad, a 250 ad.
That's right. All right. And let's just take one last question, which is, again, I think quite a people are confused about this. So would you recommend to prescribe added plus lenses for patients or kids who are not yet myopic, which helps them to prevent myopia? Or if I may put it in other words, like, let's say there is a strong family history of myopia, would you start patients or kids who has a strong history of family myopia on anti-myopia strategies, even if they are not myope? Any thoughts or any experience in that?
Well, I think it builds trust with the parents to have the discussion about prescription development. And if they're worried about myopic development, you could prescribe plus lens or an ad for the patient. But what's very interesting here is the non-myopic child, why is it they stay emmetropic and they don't progress? I don't know the answer. I have 3 kids. One child, the oldest one, is -6 with 250 cylinder astigmatism. My wife is a -2. I was a -3. So she was more than double our prescription and astigmatism also. The 2 others, perfect emmetropes. They are on their phones all the time. They're good students, smart. Yeah, they're 22 and 19, and they still do not wear glasses. I didn't prescribe anything for them, but they were outside. My son played football and golf. My daughter, she ran track and she was in cheer. They were outside a lot.
Yeah, so I think indirectly they were on more of an outdoor activities, doing their footballing and other stuff. So that would probably have helped them to not be myopic. Yeah. We don't know. As you said, it's a very broad. Myopia is something that's not understood.
I think it's a good idea to maybe try to slow down the progression of myopia, but it's not a terrible disease. We can prescribe for it. Once they get to the 18, 20, it's stable. They can wear contact lenses. They can have LASIK surgery. They can
get a vision.
If you knew you could prevent someone from becoming -9 and they were only -4, I think that was helpful, but they're still nearsighted.
Okay, right. So that's again useful. But let's say if this kind of genetical influenced myopic patients we have, do you think just by advising the kids to go outdoors for, starting a management of, as you said, talking to the parents is really important, and they must know that there is a risk of the kid to develop myopia in the future, which we don't know. They might or they might not, as you gave an example of your personal scenario. But do you think that telling these patients, parents who have myopia, that, your kids should be going outdoors more and starting those kind of managements rather than prescribing something at this point of stage would be a beneficial
I do think so. Just like you say, multifactorial, I think probably the most common denominator is, the sun. We all are around that, experience that. So the one most common thing that they say can be helpful, it would be to go outside. I would recommend that.
That's right. Yeah. So that goes by default, I think, to every kid we see, because we don't know who is going to turn myopic. So I guess that should be in our management plan, that we should be emphasizing on outdoor more, and even if they are myopic or not myopic or whatever the case may be, I guess that should be the plan ahead.
Yeah, I don't think it's going to be 100% because when I was growing up, we did not have the internet. We didn't have the cell phones. Mm-hmm. we didn't have the computers, so we had to play outside. But I still became -3.
Okay. Yeah. So again, so at least we know that nothing is 100%. Emphasizing that also again becomes our role as primary eye care practitioners, that we are just trying these strategies. Some places it works, depends on a lot of factors. So again, telling the patient that it doesn't mean that I tell you to go outside to play 2 hours as per BHVI recommendation, doesn't mean that you are not going to be myopic, right? That's not going to happen. But at least there are literature support saying that it has worked for X number of people, and why there is no harm in doing that, right?
I really appreciate y'all staying with me this long. At least it's not a business day.
Yeah.
Most of the time, if we have a meeting, like my Rotary Club meeting, it has to be 1 hour. We got to go back to the office, back to work. So from noon to one, it's over. A lot of these continuing educations that we have too, if it's 1 hour, at the 1 hour, everybody dropping off the call. But I'm very impressed. We still have 55 people on there.
Yes, I think it's because it's a kind of hot topic, and we always want to get opinions and experiences, ideas. So thank you everyone for staying along, and with that I think we have taken most of the relevant questions. So thank you, Dr. Sun, for sharing your experiences, your thoughts, and your views about how should we go about myopia prevention. Thank you so much.
Thank you very much. Good night.
Good night. Good night. I think I won't take much of your time. I do understand it's almost, I guess, 11:15 at your end. It's too late. Thank you very much.
I appreciate it. Take care.
Most welcome. One more announcement which I would like to emphasize on is Online Optom Learning Series has been working closely with the British Contact Lens Association, and there is a virtual conference happening very early next month. We do have a session planned next weekend. So thank you everyone once again for joining in today. Take care, be safe, and I hope to see you all again next week. Bye-bye.